hormonal investigations in endocrine practice. Now, as we know, this is a huge topic to be covered in 20 minutes. So I'm going to restrict myself to two very common disorders which we see in day-to-day practice. And those are the pubertal disorders and thyroid disorders, and how the lab investigations would help us to diagnose these conditions. Let us start with the puberty first. What essentially is puberty? Puberty is the stage of transformation from sexually immature child to a potentially fertile adolescent, during which secondary sexual characters appear and the ability to procreate is established. Now, I know all of you know this, but just to revise the basic understanding of the puberty, let us consider the HPA axis, that is the hypothalamo-pituitary-adrenal axis. GnRH is a hormone secreted from the hypothalamus, which acts on the pituitary to cause secretion of LH and FSH. Now, this LH and FSH acts on testes in males and ovaries in females, and ends in production of testosterone in males and estradiol in females. It also produces a hormone called as inhibin, which has a negative feedback on the FSH secretion. Now, this basic physiology is known to all of us, but what is new is that we know now there is something else other than GnRH which controls the secretion of GnRH. And this is called a GnRH pulse regulator, classically consisting of a substance called as kisspeptin. Now, this kisspeptin is under the control of various central as well as peripheral signals, and all of them together govern the release of these hormones, thus inducing puberty. Now, what are the various components of puberty? For a girl, the classical puberty goes through these three stages. First is the thelarchy, that is development of breast tissue, followed by pubic and axillary hair, and then happens the menarche. For a boy, it is first starts with the testicular enlargement, pubic and axillary hair, and then ends up in spermarchy. And this is how the puberty normally progresses. One has to remember the sequence of puberty is same in boys and girls. The timing of puberty can vary from individual based on multiple environmental, genetic, and other factors. Now, coming to the hormones especially, whenever there is puberty, there is change of FSH and LH. Both FSH and LH increase, but maximum increase occurs in the LH hormone. The testosterone, which is released in the males, causes development of sexual hair, linear growth, and lean body mass, whereas in girls, estradiol causes enlargement of the breast, uterine development, and typical fat distribution in girls. This is a simple staging of sexual maturity developed by Tanner from stage 1 to stage 5. I'm not going to go in details about this. Now, the timing, like I said, is governed by rapid multiple factors, which is interplay of genetics, nutritional, environmental factors. So, what is precocious puberty? In a girl, development of breast tissue before the age of 8 years, development of pubic hair before the age of 8 years, or menarche before the age of 9 years is considered as precocious puberty. What are the problems of precocious puberty? They are twofold. First and foremost, the girl is not mentally mature to understand what menarche means and to take care of herself. And more worrisome as the endocrinologist is that because of menarche, estradiol levels go up significantly and it causes fusion of the bones, thus ending up as short stature as opposed to a taller genetic potential which the child was born with. So it ends up with a short child with mental immaturity if we get precocious puberty. For a boy, precocious puberty is testicular enlargement of more than 4 ml before the age of 9 years and presence of pubic hair before the age of 9 years. So what is delayed puberty? No development of breast in a girl of 13 years, or when the interval between the thelarchy and menarche is more than 4 years. For a boy, no testicular enlargement of more than 4 ml in a boy by 14 years of age, or interval between onset and completion of puberty is more than 4 years. So if a child falls in this category, he or she is labeled as delayed puberty. Now, to understand the concept and the importance of lab parameters, let us have a few cases. We start with the first case. This is a boy who is 7 years old and has been noticed to have increased phallic growth and presence of pubic and axillary hair for the past 1.5 years. On history, there is nothing significant in the form of headache, trauma, surgery, altered visual problems. But this child classically has history of giliastic seizures, that is uncontrolled seizures or uncontrolled laughing episode, which end up as seizures. The birth and family history was unremarkable. So what we always do, we plot them on the growth chart, which we did for this child as well. His height was 135 centimeters, so he's quite tall for his age. His weight was okay, and his mid-parental height was 160 centimeters. So if you look at this child is very, very tall for his family as well as for the population. So on detailed examination, his testicular volume was 8 ml, which is more than 4 ml, which is justified to label somebody as having entered puberty. So his 8 ml is more than 4 ml. His phallus was quite developed, and he had pubic and axillary hair. So we decided to investigate him further by doing some lab tests. His LH value at the baseline was 1.2 milliIU per ml, and we did a stimulation test to confirm that this value was high, which came out to be 12.5 milliIU per ml. The FSH, though, was on the lower side or the lower normal side. Testosterone was quite high. 910 is as good as ideal. His thyroid function test was normal, but the bone age was 12.5 years in a child who was 7 years. So what if we look at the slide, what do we get? We know that this child is advanced in bone age of a child of 7 years. He is 12.5 years. He is very tall for the family as well as for the population. His hormonal levels show increasing trend, especially the LH, and testosterone is as high as adult. So on these factors, we can safely label this child as a case of precocious puberty, mostly central. Why central? Because we have changes in the physical appearance of the child. The testicular volume is more than 4 ml. So this is a central precocious puberty. We investigated this child and found a hypothalamic hamartoma, which was the cause for his central precocious puberty. Similarly, we have one more case. Now, this is a boy who is 8.5 years old, and again was brought to us with complaints of increasing phallic size for the last 2 years. Parents also specifically tell us that this child is getting darker day by day, and the darkest among the family members. He has severe temper tantrums, get in fights with siblings and his friends, and on probing, they also comment that this child is tallest among his friends and others of the same age group. Nothing in the history at birth or family will be suggestive of any contributing factor for this child. Neither there is history of any drug treatment or drug intake. Again, we follow the same procedure of plotting on the growth chart. This child is hypertensive slightly. 110/70 for a child of 8 years is slightly high. His height is taller for the population as well as the family. Weight is okay. Now, when we examine him, his testicular volume is 2 ml, which is not 4 ml. Label somebody as entered puberty. So his testicular volume is only 2 ml. The phallic size is quite large, and he has presence of pubic and axillary hair. So we decided to investigate him further. So this is his picture. If we have a look at this, he has significant phallic size, significant hypertension of the axilla, the nipples, and the groins and the knees. So we investigated this child. His bone age was 11.4 years for age of 8.6 years. So he's about 3 years advanced as far as bone age is concerned. His FSH, LH, both are in the normal range. So FSH is 1.36, LH is 0.1. But his testosterone is very, very high, 910, again like an adult. So if we just recollect what we just saw in this child, we have a child who is tall. We have a child who is showing signs of puberty, but the testicular volume is less than 4 ml. His lab parameters tell us that he has normal hormones, but high testosterone. So where is the testosterone coming from in this child? In a person, if the testosterone is not coming from the brain, it has to come from either the gonads or adrenal. So this boy is making a testosterone from either testes or his adrenals. So probably we are looking at a child with adrenal disorder or testicular disorder. We investigated him further and found that his 17 OHP is significantly high. The cortisol is low, ACTH is quite high. In fact, we did stimulate the cortisol, which also turned out to be very, very low. And DHEAS, which is a marker of adrenal function, is very, very high. So this child probably has an adrenal disorder contributing to development of his secondary sexual characters. And this is a case of peripheral precocious puberty. And in this case, this child has a CAH, congenital adrenal hyperplasia, leading to development of pubertal signs, but it is not from the center, and that's why it is called as peripheral precocious puberty. So what did we learn from these two cases? Central precocious puberty is less common in boys, more common in girls. In girls, it is generally idiopathic, where a cause is not found. But in a boy, if he has a central precocious puberty, is generally organic in nature. Baseline value of LH of less than 0.3 is normal. Sorry, a baseline value of LH more than 0.3, estimated value of more than 5 suggests central precocious puberty. A value of testosterone more than 25 nanogram per dl or estradiol more than 10 picogram per ml indicates high levels of testosterone and estradiol respectively, indicating presence of puberty in the individual. Bone age is always advanced in CPP. USG abdomen in a girl would help in case of peripheral precocious puberty. MRI brain generally is required when you have a central precocious puberty. And what are the various indications for doing MRI? It should be done in all boys with CPP, all girls less than 6 years of age with central precocious puberty, or a girl between 6 to 8 years who shows rapidly progressive clinical signs and associated with neurological or visual defects. We have one more case. Now, this is a girl who is 14.2 years of age and is brought to us with the parents who are concerned that this girl does not show any signs of secondary sexual characters, neither has she attained any menarche. So she, on examination, has no breast development, no pubic axillary hair. Parents also say that she's the shortest in the class and shortest among the friends. Nothing specific in the birth history. Blood pressure was normal. For the height, it's only 118.5 centimeters for age of 14 years. So she is very, very short. Weight is about 20 kg. BMI is also low. The parents are not very tall, but the target height is 153. And this girl, in spite of having short parents, is still shorter for the family. As I said, we had sexual maturity rating, which was pre-pubertal, but examination showed this girl had a wide carrying angle, short neck, short fourth metacarpal, and low lying hairline. These are some of the pictures. You can see the webbing of the neck classically seen here, and you can see the short fourth metacarpal. When you compare the fifth, the fourth is as good as fifth. So this is called as short fourth metacarpal. And this goes in favor of a syndrome, which we'll discuss shortly. We investigated this child by doing the bone age, which was 12.6 years. It was about 2 years lesser than the chronological age, which is the physiological age. So the bone age is not significantly delayed. But what was interesting is her FSH was very, very high, and her LH also was very, very high. So high FSH, high LH, low estradiol goes in favor of something called as hypergonadotrophic hypogonadism. Because of hypogonadism, she has no secondary sexual characters, but her values of the hormones are very, very high. So this condition is hypergonadotrophic gonadism, and the commonest condition which you see in practice is Turner syndrome. So this girl was investigated, we showed streak ovaries and infantile uterus. Serotype was confirmatory of Turner's syndrome. So these are 3 cases which I took for assessing the pubertal disorders, and now we move on to the thyroid. Before that, just to learn some points from this case, unexplained short stature in a girl should always rule out Turner's at any age. Delayed puberty is less common in girls than boys, but if seen, is most likely to be pathological. When you have a Turner's, we have to manage her by gradually inducing puberty and then also planning for giving growth hormone to achieve some increase in the height. So coming to thyroid disorders, and I'm going to speak only on the juvenile thyroid disorders, they could either be hypothyroidism or hyperthyroidism. Most common cases which we encounter in practice are hypothyroid disorders, and how to differentiate them from congenital hypothyroidism with the clinical features which I have not discussed now. And these patients with juvenile hypothyroidism may or may not have goiters. What are the various lab tests which we do to assess thyroid functions? This is just a list of them. We can do T4, which is the total thyroxine level in the body, T3, free T4, which is the unbound form of T4, and hence it is not influenced by thyroid binding globulins or albumin levels, and is more useful in cases where we are in doubt. Obviously, TSH, TPO antibody, marker of autoimmunity, or TRAB antibodies, which is useful in cases of Graves' disorders. And in the various scenarios one can expect in clinical practice, we can either have high TSH or we can have low TSH. With high TSH, we can have low free T3, T4, normal T3, T4, or high T3, T4. If we have a high TSH with low T3, T4, we are classically looking at something called as primary hypothyroidism. If we have high TSH with normal T3, T4, we could consider something like a subclinical hypothyroidism. We have high TSH, high T3, T4, which is rare in practice, is something called as thyroid hormone resistance or adenovirus. Whereas if we have low TSH with low T3, T4, it goes in favor of central hypothyroidism. Low TSH with normal T3, T4 again goes in favor of subclinical hypothyroidism. Whereas low TSH with high T3, T4 classically seen in hypotoxicosis. To just analyze this, let us have a few cases. This is a boy who is 11 years old. He is presented to us with a history of neck swelling for the past 3 to 4 months. If you can see this is a classical goiter, which you can see. There is history of increased fatigability. The child has good school performance. There is history of thyroid disorder in the family. On examination, this child has mild bradycardia with a pulse of 66. There is a goiter which is firm, non-tender, and there are no nodules which are palpable, whether palpable for them around the neck. Systemic examination showed no classical findings. This is a growth chart. Now you can see this child is very, very short for the population. Yeah, I'm sorry for this weight chart because it has gone slightly away from the markings which are done. But what I want to say here is this child is gaining weight, but is flat on the height and is shorter. So whenever you have a patient who is short and more in weight, it indicates that we are dealing with something like an endocrine disorder, which could be hypothyroidism, growth hormone deficiency, Cushing syndrome, or something similar to that. So short and obese. Obese in literary terms means higher in weight as compared to the height is always endocrine disorder. Okay, so we investigated this child. His TSH was 21, which is way beyond the range of 5.5, which is the highest range. His T4 was lower, 5.1 in the range of 5.5. T3 was okay. His anti-TPO antibodies were strongly positive. So what is the diagnosis? If you go back to the chart, what do we have here? We have a child with high TSH and low T3, T4. The diagnosis is primary hypothyroidism. Now at that age, with a goiter and antibodies being positive, this is a case probably of a Hashimoto's thyroiditis, which is autoimmune thyroid disorder. To confirm our diagnosis, we could do some ancillary tests like ultrasound to look for palpable nodes of goiter, or technetium scan to differentiate hot from cold nodule, multigenital goiters, or grays with thyroiditis. This is a case of autoimmune hypothyroidism, also called as Hashimoto's disease. The second case, a boy who is slightly younger, is only 5 years old, with history of loose motions for the past 1 month and significant weight loss for the past 6 months, in spite of having a good appetite. The parents are very happy the child is eating very well, but is not putting on weight, in fact, is losing weight. When we examine him, he is tachycardic with a heart rate of 140. Blood pressure is slightly on the higher side. On examination, he has sweaty hands with tremors and these classical eyes, which have significant exophthalmos. And on examination, he also has a goiter. This prominent bulging eyes, exophthalmos, is classical of a condition which we'll discuss shortly. This is his growth chart. Now look at this growth chart. This child is higher in weight, but losing weight. So there is some significant amount of catabolism happening in this child. We investigate this child further. His TSH is very, very low, 0.1. T3, higher side of normal. T4, higher side of normal. So we have a condition where we have low T3, low TSH, but high free T3, high free T4. Diagnosis, coming back to the chart, condition we have low TSH, but high 3T, high T4. Condition is hypotoxicosis, also called as Graves' disease. To confirm our diagnosis, we did the trap antibodies, which are positive. Technetium scan shows us there is increased uptake in the glands, increased uptake in both the thyroid glands. And the report also confirmed the diagnosis of Graves' disease in this patient. The third case is an interesting one, a 9-year-old boy who came to us with complaints of short stature. He is very, very clumsy, drops things very often. Handwriting has gone from bad to worse. Otherwise, he is normal. School performance was okay. He is average performing in the school. On examination, he is still prepubertal. but there is no evidence of any goiter. We did investigations for this child. Because he was short, we did IGF-1, which was very, very low. TSH was 0.5, again very low. Free T4, 0.5, low. And free T3, again low. So we have a condition where we have low TSH, low free T4, low free T3. This is his growth chart. You can see for the past year or so, he has hardly growth at all. So it's flat as far as height is concerned. Weight also is not very significantly high, also remaining probably constant. So what do we have here? Condition where we have low TSH, low T3, low T4. We're dealing with condition something like a central hypothyroidism. So we did an MRI for this child, and it shows a tumor sitting there near the pituitary. And this tumor was a craniopharyngeal. Since he had a central hypothyroidism, we investigated him further. He showed us low ACTH, low cortisol, low growth hormone, and prolactin. So definitive management here is for the tumor itself, which either can be surgical intervention or radiochemotherapy. So this child has central hypothyroidism, which we need to treat, and it is done by treating with thyroxine replacement. One is a titrated dose of thyroxine based on a TSH, not on TSH value, but free T4 levels. This child also has low cortisol and also has low growth hormone. So what do we do first? Always remember to replace hydrocortisone first. So cortisol should be replaced first. After about 4 weeks of cortisol therapy, you could add thyroxine. After about 4 weeks of therapy, you could think of adding something else. Remember to add growth hormone only after a year or two after completion of therapy. Reason is, growth hormone sometimes is considered to be tumorogenic. So if a child recurs, the tumor recurs, we would not know if it's growth hormone or recurrence of tumor itself by its own. So I just want to finish my slide by saying this, that lab investigations are important diagnosis of endocrine conditions. Hormonal levels, though important, are age specific, so you should know the cutoffs for the age when we're using them. We could use suppression or stimulation test of hormones in specific clinical situations, but all these tests should always go hand in hand with the clinical features to confirm our diagnosis. Thank you so much.